Hello everybody and welcome to this lecture on the macrocytic anemias. So I include these first few slides in all of my anemia lectures. This one just on the basics of anemia. The definition is a deficiency of red blood cells or a deficiency of hemoglobin. On the right here is a chart that shows you generally what the ranges are going to be roughly, but they could be a little different for each lab or the machinery that you're using. And of course, if you're taking an exam, use the thresholds the exam gives you. General symptoms of anemia: fatigue, dizziness are going to be your main ones that come on earlier. You'll get a little lightheaded. A little later on in the anemia, as it gets more severe, you'll start to see pallor and you'll see it on the skin. And finally, in later stages where it gets really bad, you'll see shortness of breath just because of the body. You actually have such a decrease in oxygen carrying capability. They're going to start to become short of breath. When we look into the sources and trying to come up with a differential for the anemias, one of the best first steps to do is to use the MCV method, or the mean corpuscular volume, which is just the size of the RBC, the size of the red blood cell corpuscle. And as you can see, macrocytic anemias are generally over 100, and the unit here is femtoliters, FL. Normocytic 80 to 100, and of course less than 80 would be micro. But we're going to be looking at the macrocytics over 100. This is a table I pulled directly from UpToDate. It's a pretty good rough outline. It doesn't go into too many details, but gives you an idea of some potential culprits for each type of anemia. And today we're looking here in the MCV over 100, of course, for the macrocytics. So one of the first things to always keep in I was going to say the back of your mind, but it really should be the front, because it almost certainly would be the worst, is malignancy. Malignancy on its own can cause macrocytic anemias, although it could cause other types of anemias, not necessarily macrocytic, but normocytic. But it could also cause macrocytic anemias through vitamin deficiencies and other mechanisms. So you always want to think of malignancy as a possibility. And of course, we all know our red flag signs for malignancy, things like weight loss, your B signs like night sweats, those types of signs are always red flags and should make you think this. Also look at the other cell lines. Is the white cell count also down, or is it through the roof? Like it could be in a leukemia, the platelets. So the other cell lines can point you towards or away from malignancy as well. And then just more specifically, MDS, which is myelodysplasia, marrow failure, and other malignancies, including some solid tumor malignancies, absolutely can give you a macrocytic anemia as well. You also want to look out for hemolysis. We don't usually think of macrocytic with hemolysis. Usually you'll think normo and sometimes micro, but just keep it in the back of your head. These are some of the things that could be causing it. So you'll see the most common cause of a macrocytic anemia, which is listed here, is a B12 or folate deficiency. And this is really what comes up and what is tested most commonly on USMLE, both Step 1 and 2, and the COMLEXs, of course. So you're going to find in the B12 and folate deficiencies, first of all, remember the neuro findings, that you're going to find those in the B12 and not really in the folate. You might hear mixed things about neuro findings and folate, but for the exam, really, you're only going to think of neuro findings with B12. And that has to do with B12 affecting myelin and the dorsal cords and all those spinal pathways. Think of the patient's diet. So a lot of times a vignette will tell you, a patient has been taking on a vegan diet for the last few years, and they're suddenly anemic. Well, folate is in a lot of greens and things like that. That's where the word comes from, foliage, folate. But B12 is predominantly in meat products. So think about that. And of course, other things like if you have alcoholics or things like that, these people tend to be nutritionally deficient. So this is something to think about. And then finally, one of the biggest kind of clinical pearls that's always hammered home is on the pathology. On the peripheral blood smear, you see hypersegmented neutrophils, which you could see here, just clearly too many lobes. And if you're ever on a path rotation or hematopath or even just hematology and you want to impress your preceptor, the actual definition of a slide with hypersegmented neutrophils is multiple neutrophils with 5 or more lobes, or if you just have one neutrophil with 6 plus lobes, that would meet the criteria for hypersegmentation. And looking here in this lower neutrophil, a little fun fact that will also a good party trick, if you will, if I don't know when you'll have a microscope with a PBS at a party, but this little dot, the small purple dot in the lower neutrophil here, that's actually a bar body. So if you recall, in females, one of the X chromosomes is kind of muted and that becomes a bar body. So you could tell actually just from a PBS that this is a female sample, just from the bar body. So I think that's kind of a cool little trick. And lastly, some other causes, liver disease, alcohol use, we kind of discussed that. That kind of goes hand in hand with nutritional deficiencies. Thyroid dysfunction, which if you watch the other anemia lectures, thyroid dysfunction can cause normal and microcytic anemias as well. And that's because thyroid can directly kind of cause these things, or can indirectly through iron metabolism and through other metabolistic kind of dysfunction that the thyroid is so essential to keep up. HIV as well. HIV affects bone marrow. It affects just about everything. For the test, there's certain things they want you to know about HIV, but once you get into rotations and practice, I've kind of picked up that HIV is one of those viruses, one of those pathologies really that could just do whatever it wants, honestly. A little less common is copper and zinc deficiency. We don't think of those all the time, but it can absolutely lead to macrocytic anemia. And then iatrogenic. Always think about, reviewing the med list. What are we giving the patient? Is there anything that we're doing that could be causing this? And then finally, some of the congenital things that are super rare in real life, but the tests just love to throw on there is erotic aciduria, Fanconi anemia, and diamond black fan anemia. I won't go into too much detail here just because they're a little nuanced and not too common, but if you stick to this, I think you'll do well, and thank you for watching this video with me.